Endometriosis is more common than we realize. It's truly a chronic systemic disease with multiple effects throughout the body. It's actually up to 11 years from time of symptom onset to diagnosis. And not only that, patients often go through 4 to 5 physicians to ultimately reach that correct diagnosis. Through our labs, we've learned that
Dr. Valerie Flores is a Yale-trained reproductive endocrinologist who's really challenging the outdated norms around endometriosis, shifting how we understand, how we talk about it, and care for patients, which is often a misunderstood condition. But she's not just stopping at the research. What she's really doing is she's working on building her brand and educating beyond the clinic to showing other healthcare providers what is possible when treating this difficult condition. So really, this isn't just about infertility. It's really about visibility, voice, and understanding. So welcome to Med Story. And Dr. Flores, are you ready to get into it?
I am. Thank you so much for that wonderful introduction. It's really exciting to be here with you today.
So tell me, if we were to go on the top of a rooftop and you were going to shout something at the top of your lungs, what would it be and why would you want the world to hear it?
Oh, it would definitely be about endometriosis and recognizing that it's a chronic systemic disease. It's been really challenging to understand that, both from a patient perspective and even from a clinician perspective, and also recognizing how common it is. So I'd shout, I guess, 2 things. One is that endometriosis is more common than we realize. And 2, it's truly a chronic systemic disease with multiple effects throughout the body.
My understanding with endometriosis is that in the current model, the actual life cycle of coming to a diagnosis is like 5 to 7 years. Is that correct? And if so, why is it so difficult?
It's even longer. It's actually up to 11 years from time of symptom onset to diagnosis. And not only that, patients often go through 4 to 5 physicians to ultimately reach that correct diagnosis. And so we used to think it was something that affected reproductive age women, for example, but really it probably starts in adolescence. And so even diagnosing it that early on, 1, is possible, and 2, is something we should really be asking patients. But you bring up a really good point, which is why. And why is because 1, there's no one symptom that manifests as endometriosis. So we commonly say pelvic pain is one of the most common symptoms that patients struggle with, but that's not always the case. Some patients have no symptoms whatsoever. Some patients have chronic pelvic pain. Some patients, actually, we only diagnose them because they're presenting to my fertility clinic and trying to figure out why they're not getting pregnant. And even when it comes to patients having surgery for pelvic disease or for looking for endometriosis, there isn't always a classic appearance. And so that really makes it hard for, 1, providers to feel comfortable diagnosing the condition, and 2, even patients have a hard time just from the perspective of social norms. I often have patients coming in and saying, my mom had really painful periods. I was told that's just the way it is. I just had to suck it up, and periods were supposed to be painful. But that's, 1, totally wrong. When periods are so painful that you're missing school, you're passing out, you're throwing up, that's not normal. It is okay to have some type of cramp. And if Motrin resolves that pain, that's less likely to be endometriosis. But when patients, I often hear these stories of patients saying they had to miss school or they couldn't get out of bed. Those are usually going beyond a normal menstrual cycle. And often their parents, their mother also had endometriosis. We know that you're 7 times more likely to have the condition if you have a first degree relative. So actually even understanding from that perspective that maybe their mother or their grandmother or their aunt had endometriosis, and that's why the periods were so painful. But really, the other important point to recognize, again, is this chronic systemic disease. So what I wanted to talk a little bit about is just what exactly is endometriosis, because I think that's also hard for people to understand sometimes. And I think as we explain a little more about what it is, it might hopefully make it easier to diagnose patients. So endometriosis, oh, sorry, go ahead.
No, please tell me. I want to know.
Okay.
What is it?
Yeah. So endometriosis is a condition where essentially when a woman has a menstrual cycle, the blood is supposed to go out through the vagina. But sometimes it refluxes backwards to the fallopian tube and implants on different areas of the pelvis. And because it's like the lining of the uterus, each month it will grow in response to hormones. And just like the lining of the uterus sheds each month, it's also shedding, except there's no place for it to go. So it stays in the pelvis and it causes a lot of pain, a lot of inflammation, because the immune system is trying to say, oh, this blood's not supposed to be here, this tissue's not supposed to be here, but it has a hard time actually removing that tissue. And so it's this chronic cycle of inflammation, pain, and it can affect various organs. We commonly think of it affecting the pelvis because it does tend to implant in dependent areas, but we are learning more and more that it can affect really any organ system. And so when we get a better understanding of what endometriosis is, it does help in terms of diagnosing patients. So we tend to see a lot of cyclic pain. So cyclic bladder pain, cyclic bowel pain,
What
menstrual
is that?
pain. Yes. So cyclic bladder pain is really patients will complain that either they feel like they constantly have to go to the bathroom to go urinate after during their menstrual cycle, or they just feel this like cramping type of pain around their bladder area. They can have pain with bowel movements. They can have a lot of cramping associated with bowel movements. I get a lot of patients who have seen a urologist, a gastroenterologist, and no one bothered to ask when do they have these symptoms happening. So it's really the cyclic type of pain that's the more common association with endometriosis.
Why are you so passionate about this?
My aunt actually struggled with endometriosis, and it was around the time that I started medical school that she told me her story. And it was also around that time that I met my mentor, Dr. Hugh Taylor from Yale, who is another endometriosis expert. And it was through her physician, my aunt's physician, actually, that she ultimately was able to have two children because she had endometriosis related infertility, actually, more so than the pain component of endometriosis. And so, hearing her story and hearing what a pivotal role her provider played, that's something that really inspired me. I wanted to be able to do that for my patients. And also, as I started to learn more about the condition and how really it's a silent disease in some ways, and that patients don't always feel comfortable bringing it up, and providers don't always feel comfortable talking about it or diagnosing it, it's something that really motivated me to advocate more about the condition. And I did that. I do that both from a research perspective as well as from a clinical perspective, and through opportunities like this to increase awareness about the condition as well.
Okay. And then so can you tell me about the work that you did with Dr. Hughes at Yale?
Dr. Hugh Taylor, yes, at Yale.
Sorry.
So I did translational research. So I looked at one, the pathophysiology of endometriosis, and two, looking at why a lot of the more common hormonal therapies that we use to treat pain, why they're not always effective for patients. And then the third thing that I looked at as a reproductive endocrinologist was how is endometriosis contributing to infertility? So, one of the common things that we see with endometriosis is something termed progesterone resistance. So, when I was talking a little bit about how endometriosis can cause all those pain symptoms, so what happens is during the first half of a menstrual cycle, estrogen is the dominant hormone. This loves estrogen. It loves to grow in response to it. And ultimately, the second hormone that comes on board after ovulation is progesterone. Progesterone normally tempers the growth of estrogen related growth of the lining of the uterus. And so, in the same way for the endometriosis, it should be tempering that growth of the endometriosis. It should essentially make it stop growing. But even though women with endo, women without endo have the same levels of progesterone, the endometriosis patients or the endometriosis itself doesn't respond to a given person's own natural progesterone. So that's what we term progesterone resistance. And we, up until recently, didn't know why. We didn't know why women with endometriosis were resistant to progesterone. So my first projects were looking at, so really looking at, is it something at the molecular level where we know progesterone is supposed to bind to its receptor? That's how it mediates this tempering of the growth of the lesions or the lining of the uterus. So could it be that maybe there aren't a lot of progesterone receptors in the endometriotic lesions? And I found actually not only was that the case that we actually see lower levels of progesterone receptor, but on top of that, we can actually use it to predict response to progestin-based therapy, which is typically first line, but we also know that up to a third of women fail. So really that first project was looking at more, one, why is it that we have progesterone resistance for patients? The next step was then looking at, we had a subset of endometriotic lesions where actually they did have progesterone receptor, but they did not respond still to progestin-based therapy. So I started looking at more downstream effects. We call them post-translational modifications. And what I found was that there are some cases where the progesterone receptor is there, but there's something else attached to it. We call it sumoprotein. And that protein prevents progesterone receptor from doing all of its downstream effects. And then from a fertility perspective, we also found that patients with endometriosis related infertility Again, they may have that progesterone receptor, but this little protein's attached to it and doesn't let the we kind of block that protein's ability to bind to the progesterone receptor. So that way we can, again, restore normal progesterone activity at the level of the receptor.
I want to make sure that I understand this as a male and what
Yes.
you're telling me. So let me say what I'm understanding what you're telling me. So
Okay.
within our ovulation cycle, we have estrogen, which elevates during part of it, and then after ovulation, then
Mhm.
progesterone elevates.
Yes.
And what you're saying is that typically progesterone would calm down those symptoms.
Mhm.
However, in
Exactly.
endometriosis, they either don't have the receptors where the progesterone
Mhm.
can bind, therefore the pain stays elevated, the symptoms stay elevated,
Yep.
or there is a protein that is attached to those progesterone receptors that is
Mhm.
inhibiting the downstream effects of it. Is that right?
Exactly. You got
Okay.
it.
Okay. Sweet. Thank you. So
Thank
now,
you.
how do we tell this story though in a way
Yeah.
that the layperson can understand?
Yes, exactly. So I think what's really important to let patients know is that if they think they have endometriosis, to seek out reproductive endocrinologists and fertility specialists. So whether that's me or whatever state you're in, really seeking someone out who has that level of expertise. Or really advocating in the sense of recognizing that these symptoms are not normal. We shouldn't be normalizing pain with periods. And so, really advocating for that referral to see a specialist, because it's not so much that we expect everyone to be able to take care of this condition, because it can be, again, really complex. But if we can at least direct patients to the right place to go. And then from there, how we can simplify it, because I know it's a lot to take in, is really just saying that in patients with endometriosis, pelvic pain is a big symptom that patients can experience. And so, one of the ways to treat that outside of fertility is giving a medication that basically gives you extra progesterone. So, that can be a progesterone only pill, that can be a birth control pill, or that can be an injection of progesterone that patients can get. When that fails, one, we shouldn't give a long time to have to figure out if patients are responding to that medication. I usually give 6 weeks to 2 months. If patients aren't feeling better, then that's when we have to think about, oh, maybe maybe their endometriosis is progesterone resistant. So let's use a different medication. So the other hormone we talked about is estrogen. Let's more specifically block estrogen production, because if we know endo loves to grow with estrogen, if we can block that, then that's another way to target the endometriosis pain. And we don't have to involve progesterone if we know that they're not responsive to it. So that's where I'd say we know progesterone resistance is common. We have to keep that in the back of our minds when patients aren't responding to progestin based therapy. And rather than just switching them to another progesterone therapy, we should just actually switch the class of medications completely and give these medications that actually more specifically lower estrogen production.
So you said that someone should be able to go and see a reproductive endocrinologist like yourself.
Yeah.
I'm guessing that is a highly specialized position, and it makes me wonder about access. Is it easy to access someone like you through the current healthcare model? And are there enough providers like yourself?
Well, we always need more. There actually is currently a shortage of reproductive endocrinologists and infertility specialists, but we always need more. And so the other part of advocacy and increasing awareness is also empowering OBGYNs, for example. So in order to become a specialist, a reproductive endocrinologist and infertility specialist, we do not just medical school, but we actually also go through a residency in obstetrics and gynecology. Then we go through a fellowship specific for reproductive endocrinology and infertility. So another component of this is really also empowering the general OBGYNs to say, okay, this is a condition where maybe I don't have a reproductive endocrinologist immediately available to refer to, but at least seeking out that second opinion in the sense of saying, oh, I can contact this doctor and actually ask her, is this how I should be managing this endometriosis patient? So really fostering that collaborative nature. They may have a hard time getting to my office, but I have no problem having some OBGYNs contact me and saying, can we co-manage this patient? She can't get to your clinic, or not possible for her to get to where you are. Or maybe there's an insurance issue, but definitely being open to co-managing the patients so that they still get the care that they deserve, and that the OBGYNs also feel comfortable managing these types of conditions as well.
And how about from a public relations standpoint of you getting this information out there? Do you feel that there is a best way to communicate it or a best avenue that interests you the most right now?
Yeah, I think one way is being able to be on your podcast because I know you have a very large following and being able to increase it from that perspective. The other ways that I've worked on this is also through my clinic. And so on our website, we do have a lot of information about endometriosis and seeking access to care. I also am involved at several reproductive endocrinology conferences where I, from a research perspective, really increase awareness about the condition and ways that we can advocate for patients. And actually, a few weeks ago, I was actually at a general OBGYN conference where I spoke about endometriosis being a chronic systemic disease and also really talked about how we can shorten time to diagnosis to get patients to where they need to be to have that treatment. So those are other ways that I'm working on really increasing that awareness. And also through publications that have the opportunity to publish both in basic science journals as well as more clinical journals, increasing awareness and really talking about how we need to shift the paradigm around endometriosis because again, we talk about it as a pelvic disease, but it's really important to recognize that it is a chronic systemic disease with multifactorial effects throughout the body. Through our lab and some other labs, we've learned that it affects areas of the brain associated with anxiety and depression. It alters pain perception. It actually alters metabolism. A common misconception was that if you were thin, that was a risk factor for endo, but it's actually the reverse. If you have endo, you're at risk of being thin because it does cause a lot of changes with anorexia-genic genes, so basically genes associated with metabolism. And then altered pain perception is huge. We see a lot of patients where something that may not cause any pain to someone without endo is extremely painful to patients with endo. And so I see a lot of patients who will say, yes, I have pelvic pain, but I also have chronic pain and I also have altered pain sensitization, or I have irritable bowel syndrome, or I have a lot of anxiety and depression. And really being able to talk to patients and let them know that it's not that there's something wrong with them, it's truly the endometriosis that is affecting all aspects of their organs. And then again, really emphasizing the important role of medication because it also has systemic effects. So I've had patients whether they may not be seeking fertility, they're seeking more pain management, and they'll come back and not only is their pain gone, but their mood is better. So that's really exciting to really be able to target all of these different aspects of the disease.
This is actually pretty cool because I just had a conversation yesterday with a psychiatrist who was talking
Oh,
about
yeah.
with a chronic pain. And what she was saying is basically what happens is when someone is getting that consistent and chronic pain signal that goes up their spinal cord to their brainstem, it will start bouncing around your brain. It will start going through
Mhm.
your limbic system, through triggering your memories, your prefrontal cortex. And that repetitive stimulus will actually cause portions in your brain to atrophy, meaning we can release less dopamine and leads to depression, things like that. And we think about the whole chain of effects here. And I could see where actually identifying and coming to the diagnostic of something like endometriosis, which is the root of it, can be so
Mhm.
valuable, right? And so
Yes, exactly.
if there was one step that we need to take today to shorten that time period, to shorten that period that we can come up with a diagnosis, like what is the next best step for us?
The next best step I would say is really listening to patients and well, actually asking the question about what their menstrual cycles are like, I think is question number one. And then the step after that is really listening to patients. And again, really focusing on what is the patient telling you from their symptoms perspective, which is like med school 101. We learn all about the patient physical exam, the patient interview, the history taking that's involved in that. I think the two big, well, I think three. One is recognizing how common it is. We say it affects 1 in 10 reproductive age women. I think that's probably an underestimate because, again, it can be so hard to diagnose. Two, asking patients about their menstrual cycles. It's like a vital sign in some ways. And so asking patients about their menstrual cycles. And again, if patients are saying that it's so painful or that Motrin's not relieving it, or it's to the point where they can't get out of bed, they can't go to work, that's not normal. And so at that point, really investigating it further or referring to a provider that is an endometriosis specialist as well is ideal.
I hear what you're saying, but I want to play some devil's advocate here
Of
because
course.
because what I have learned after having several conversations with OBGYNs, even urogynecological surgeon, is that number one, the healthcare system reimburses female surgery and
Mhm.
care at a lower rate they do males, which is totally unacceptable. And what I'm
Yeah.
finding is that is actually forcing our OBGYNs to see more patients in the same amount of time, which means less time with the patients. And so I get the idea of that OBGYN saying they have to listen and dive a little bit deeper, but they're struggling to find the time to do that. And so
Yeah.
if we know this to be true, what could be some potential solutions?
Yeah. So one is I would say, again, yes, I have friends who are general OBGYNs who are amazing general OBGYNs, but they do tell me that the time that they have for a new patient is 35, 40 minutes. The time for a follow-up is maybe 20 minutes. And so I think one option is to say, yes, we all have very busy clinics. I would just get the question started. If at that point you realize this is something, this is a condition, whether it's endometriosis or not, that's going to take more than the allotted time, validate the patient's feelings and bring them back in for a follow-up, or say, or at the very least say, okay, it sounds like you might have something like endometriosis. That's not necessarily my area, but I'm going to refer you to doctors so that they can also help manage that as well. So I think there's always room to say, I think it's totally appropriate to say, this is something that actually would require a follow-up appointment or another appointment to go through in more detail. So just getting the question out there to even know that this might be something going on, and then scheduling them for a follow-up or referring them to another provider, I think is absolutely okay.
Do you think that there could be any role in an AI, for example, if someone was coming into the patient or the waiting room and they fill out those
Mhm.
intake forms, which are
Mhm.
either in paper or digitally, but is there currently any system that based off of all the check marks that they do, that it will alert the clinician to say, hey, this person has a higher risk of having endometriosis? Is anything like
Yeah.
that currently in place?
Actually, there isn't. There are a lot of questionnaires that exist to look at pain components for endometriosis and also look at how it affects quality of life. Those are more focused on when we start a treatment for a patient and from a research perspective from clinical trials, looking at, okay, is this treatment lowering that pain score? Is this treatment improving their score for quality of life? But I think actually you bring up an excellent point, which is something that we could do. We all of our patients fill out intake forms, whether we think they have endometriosis or not. And one of the questions on there is, do you have painful periods? But I think expanding that even further to get into more of, and do you also have to take time off of work? Or is it to the point that you have painful intercourse? Because that's another symptom actually of endometriosis. So I think actually that would be awesome because then again, like you mentioned, it is hard to get into the office and it's also hard to have all the time that you need to go through everything. And so if you already have that alert going, then you can help triage that patient to the appropriate person as well.
Exactly. And I think this is something that's so exciting with the potential of it, where I think actually
Mhm.
introducing these kind of solutions with AI is going to increase the amount of human connection that we can have. Because
Yeah.
imagine you come in there saying, oh, wow, I'm already triggered. This could be something potential. I can
Yeah.
get to these pointed questions right away rather than running
Mhm.
out of time. So I think
Yeah.
it's pretty cool. What do you feel within this space of endometriosis and infertility? What is something that excites you the most about it?
Yes. So I think what excites me the most is a clinical trial that I'm actually involved in right now through Yale. So patients with endometriosis, we know that there is a decrease in fertility potential because endo can cause inflammation at the level of the eggs. It can affect the sperm traveling through the fallopian tubes, and it can affect the uterus undergoing the change that it needs to undergo for implantation. So something called in vitro fertilization, which is one of the fertility treatments that we offer for any patient, but in particular for endometriosis patients, works very well. And it's because it targets literally all the aspects of where endometriosis can affect fertility. One, with in vitro fertilization, we actually, by giving patients injectable hormones to get lots of eggs to grow, we ultimately retrieve those eggs through a vaginal procedure. So we take them out of that inflammatory environment. We combine the sperm with those eggs for fertilization in our embryology lab. We watch them develop into embryos. And then again, we're bypassing that tubal transport because we'll put that embryo directly into the uterus. But even with in vitro fertilization, the success rates for patients with endometriosis is actually slightly lower than other infertility conditions. So there's something else going on that we need to be able to better target so that we can help get them to the success rates of patients without endometriosis. And so that's what this clinical trial is doing. And it's again going back to that progesterone resistance component. So with endo, just like the endometriosis becomes resistant to progesterone, the lining of the uterus becomes resistant to progesterone. And progesterone is really important for implantation. So what we're looking at is giving patients for 2 months an oral medication that lowers their estrogen levels. And the one, it's already approved for treating pain with endometriosis, but the thought process from a fertility perspective is If we are basically going to reset everything, if we lower estrogen, we're going to lower it, move this progesterone resistance, so that once we do an embryo transfer where we give patients back the progesterone, estrogen and progesterone to get their lining to grow for the implantation process, now we've reset the uterus. We've reset the uterus to say, okay, you didn't want to respond to progesterone because of all that endometriosis, but now I've gotten rid of the endometriosis with this medication. So now the uterus should be better prepared for implantation and responding to progesterone. There have been some small studies with another type of medication that did show improvements in clinical pregnancy rate, which is looking at after we do an embryo transfer, we do an ultrasound a few weeks later, well, a pregnancy test, and then ultimately an ultrasound, and we see a very early pregnancy in the uterus. This study is taking it a step further. We want to see not only are clinical pregnancy rates better, but actually do we see more live births? And do we also see decreases in some of the pregnancy complications that go along with endometriosis? So that I'm really excited about because, again, IVF, it was really that we would say IVF is the best we have. And then we would say, oh, but actually the success rates are still a little bit lower if you have endo. And now we're saying IVF, not only is IVF the best we have, but now on top of that, we have another medication we're going to give you to really help make sure that you have the best success rate. And so that's really exciting. It's some NIH funded research, and there are a couple of different clinics that are involved in this. And they're wrapping up enrollment. So hopefully in the next few years, we'll have the results. But this is something that's really new and innovative in the field right now.
This is really exciting stuff. It really is.
Yeah. Yeah.
Now, if a woman is listening to this right now, she has endometriosis, she is in her fertility years, going through pain, she's suffering, she has unanswered questions. What do you want to say to her?
You are not alone. And you should not have to feel alone, and you shouldn't have to feel like endometriosis is something that you caused. Because one, we still don't exactly know why patients get endometriosis. And two, what's really exciting again is that we are talking about this more. I get patients now coming to me saying, I think I have endo. And I think that's amazing because for a long time, it was more patients would tell me their symptoms. And I'd say, has anyone asked you if you might have endometriosis? And would be shocked to even hear the term. So it's really important to recognize that these patients are not alone. A lot of the symptoms that, again, aren't necessarily quote unquote classic. So the anxiety, the depression, the infertility component, that is part of endo. And again, it's not to say that we cannot help patients get pregnant. It's actually, once we have that diagnosis, there's so much we can do, whether they're seeking fertility or pain management. We have so much available now that one, no patient should feel alone and shouldn't feel like there isn't some sort of treatment, whether it's fertility or pain management, that can work to get their symptoms under control.
I love that so much. When it comes down to it, in the healthcare system, we often feel isolated as patients and providers. And if there's one single thing that we want people to know is that they're not alone. And that's why we're here to support them. And
Exactly.
I love that message so much. So if another doctor, clinician, or patient wants to learn more about you as a doctor, as a researcher, what's the best way to find you and get in contact with you?
Yeah. So one option is you can Google me, Valerie A. Flores, MD, and you'll see both my profile. I'm still an assistant professor adjunct through Yale. So you can see the work that I've done at Yale. And then I also am part of a fertility clinic, San Diego Fertility Center. And then I'm happy to include my email if that's helpful for the podcast purposes. I have no problem with that. That's another really good way to reach out to me as well.
Amazing. All right. Well, we will make sure that we put that in the show notes below.
Perfect.
But I so appreciate this. Like the passion that you have for this is really clear. And we need more specialists like you that are not only doing the research, but then being able to tell the story behind the research so that the people can understand what treatment options are out there for you. So I think you're doing amazing work, and we will continue to have this conversation moving forward. So,
No, thank you so much.
oh,
Thank you so much for the opportunity. I really appreciate it.
it's my pleasure. My pleasure. So if you are a healthcare provider that is trying to push healthcare forward, if you want to disrupt it and really making sure that our providers are having a high quality life, but also pushing innovation forward, and you have a story to tell, please reach out to us, medstorymedia.com/podcast. And until then, we'll see you in the next one.